Okay, welcome back, everyone. I hope everybody had a great lunch. It's time to move on. This next topic is very near and dear to me, as mental health in our community seems to be a constant and growing struggle. In this segment, our experts will be discussing the many primary problems associated with the mental health economy and the ways we can tackle this. I would now like to please request our session moderator, Miss Angela Johnson, to take the stage. Come on up, darling.
Hello, everybody. I hope this fills up a little bit. Everybody's still eating lunch, I guess. So we've got a great panel for you. Anybody that's interested in mental health and working in that space, we've got some great panelists for you. So I'm going to call you guys up one at a time. So Lacey Hart. So Ms. Hart has over 20 years of deep experience in healthcare delivery disruption, 10 years of IT innovation and product development, and 5 years enabling startup ventures. So she's got a lot of experience. She doesn't look that old, does she? And she's transformed. She actually works at Mayo Clinic, and so she's been transforming customer relationship management strategy focused on patient experience journey and particularly meeting the needs of digital healthcare consumers. And so over the past 3 years, she's transformed the Mayo Clinic's management strategy with systems in an engineering lens. So thank you for joining us. So I also have Dr. Patrick Hutton. Where are you, Patrick? Great. So Patrick's the CEO and founder of NeuroInterview. So he's doing some really interesting things in helping us find the right staffing for our mental health needs in the provider side. So he is a clinical assistant professor of family medicine at the University of Oklahoma College of Medicine, and he serves as a consultant for value-based healthcare for Blue Cross and Blue Shield of Oklahoma. And his experience crosses several fields, including value-based healthcare. We've talked about that this morning, population health management, business strategy, and developing neuroscience-based models that use AI to measure and predict human emotion in high-stress settings. And who doesn't know that we have high-stress settings in the provider side? And so the next is Jill Wiedemann-West. She's the CEO of People Incorporated Mental Health Services, an innovative community provider of vital integrated behavioral and mental health services. Prior to joining People Incorporated, Jill was the CEO at Hazelden Betty Ford Foundation for 11 years. So lots of experience there. She's been leading changing initiatives of People Incorporated that will have an impact for the years to come in the Twin Cities and beyond. So Jill's expertise, enthusiasm, and compassion, and no-nonsense attitude toward helping those in the Twin Cities living with mental illness allows People Incorporated to serve more than 12,000 clients each year. And Shari, where are you, Shari? There you are. Hi. So Shari is a marriage and family therapist and adjunct professor at the founder of the Narrative Method. And if you haven't been already, she has a booth over on the other side in the lunch and sort of the break rooms. An experimental program that uses personal narratives to increase empathy and compassion for others. Shari received her MS, so a master's, I think, right? Master's? 2 masters. So in narrative medicine from Columbia University and an MA in clinical psychology from, oh boy, Ania University in Los Angeles. I'm a Canadian. I didn't get that, sorry. So where she founded the Bridge program, a free humanities program of adults without access to higher education, seeing the need for meaningful connection in our increasingly dehumanizing world. She founded Narrative Method to provide training and programs for youth, veterans, and at-risk populations. And last but not least, we have Erin Huey. So Erin, you're coming up. So Erin is the founder of Fire Mountain Residential Treatment, which provides treatment services for adolescents 12 to 17 in the Colorado area. His company is just celebrating its 10-year anniversary this year. And they also have a podcast, which is called Beyond Risk Back. And if you can find it on beyondriskback.com, that podcast is focused on providing support to parents who have children in mental health needs. They're #1 in Colorado on podcasts. They're #3 in the US. And then in Canada, they're #1. Shame on me, I didn't know about them. And #1 in Australia and #3 in UK. So, welcome panelists. This is great. So I asked each of you to give us a little bit about your business and how the economy, the problems in the mental health economy are impacting your business. So maybe we could go to the first slide. Oh, where do I go? Here we go. Perfect. Okay, so Patrick, you're up.
Test. Okay, so this slide I'm going to talk a little bit about what the relationship is between employment and mental health and the economy and mental health. So what we know through research and through my own research is that there's an inverse relationship. So as employment rises on a population basis, we tend to see a decline in mental health issues on a population basis. Same with the economy. When the economy tanks, people lose jobs, we tend to see a spike in mental health related issues. And there's also a pretty significant relationship with how satisfied someone is with their job and mental health issues. So the more satisfied someone is, the less likely they are to suffer from a job-related mental health issue. So that brings us to organizational fit. So when we're looking at organizational fit, we're talking about employees that are able to adjust to the culture, meet the job demands and the stressors of a particular work environment. One of the big things with organizational fit is just because someone is qualified for a particular job does not mean that they are a good fit. So a great example of that is, let's say we have an RN that has worked in community ERs her entire career, and now she's wanting to transition to a large inner city hospital. So just because she's qualified does not necessarily mean that she can meet the demands and the stressors of that particular work environment.
Great.
Next thing is positive job-related outcomes. So when we're looking at positive job outcomes, we're looking at people that thrive within a particular environment. They're high performers. They're able to thrive with their job responsibilities, and those people in turn typically have lower levels of stress and mental health disorders related to a job or that are triggered by a particular job. And what we know is, of course, with any company, if you have employees that are happy, they're healthy, they're thriving, and they enjoy what they're doing, you're going to have company success. And so company success, you have increases in employment, you have growth, financial growth, and what happens when companies are succeeding and growing on a national basis, that benefits the economy. So remember, there's an inverse relationship on a population basis between the economy and mental health. So when we have more success within the economies and companies are thriving, we see a downturn in mental health related issues. So employers actually do have a pretty significant role in mental health on a population basis. It's often overlooked, and but that's probably the key takeaway, and it's just really one small piece of the bigger puzzle.
Okay, thank you, Patrick. So who do we have next? Okay, we have you, Sherry.
Thank you. Hi, everybody. So I believe that we have been carrying forward old ways of looking at mental health that are really antiquated. And one of the reasons they're antiquated is that none of us were bred into a world that we had any preparation for. If a family could handle the mental health issues of one of its members in the past, Now the numbers, the percentages are larger, but the numbers are so vast that it's over the head of most families. But there's another problem, and that is the misunderstanding of what is mental health and what is normal. We are so over-pathologized. So for example, in the recent work of Bruce Alexander from Vancouver, who maybe you know, in his work with addiction, what he has discovered is that the opposite of addiction is not sobriety, it's relationships. The opposite of loneliness is the opposite of relationships is what leads to loneliness, what leads to alienation. And if this is hanging out with your friends and there's no eye contact, in a world where if you are feeling depressed or if you have anxiety, you are pathologized, we're going about this the wrong way. The world is extremely stressful right now. And if you're not anxious, there's something wrong with you. It's normal to be anxious. When we sit together in groups where there's a non-hierarchical situation without the interference of insurance, without the interference of companies that are trying to make money off of our quality of life, off of our humanity, we then have an opportunity to really look at what does it mean to be human. The way we're living now is not good enough. We all know that. It's time to take a stand and do what's right for humanity. And in short order, that means we need to talk to each other and normalize so many of these experiences that have been over-pathologized.
Great, thanks, Sherry. Okay, next we have People Incorporated.
I could probably do without. Can you hear me okay? Good afternoon. I'm with People Incorporated. We are a community-based mental health center in Minnesota. We serve about 13 to 14,000 individuals discreetly annually. Our innovation is really an innovation that is about how to treat the individual. A lot of what you're already hearing. We need to start from a place of acknowledging that we all have mental health. We're all on a different part of that mental health continuum, but that we do in fact all have mental health. And that mental health plays this vital role in everything from what we do for a living to how we move through trauma to how we manage disappointment and everything around that. The population that we serve largely through our services in Minnesota are most complex and vulnerable. They're individuals that are largely, not entirely, but largely disabled by their mental health and or their co-occurring other disorders. They may be medically fragile, they may be chemically dependent, they may have pretty significant trauma. We deal with both adults and children, and one of the things that's just so fascinating to me and that I've really dug into so much is the way that we actually look at mental health is so cohorted by either payment sources or the individual practitioner that's looking at these individuals, rather than looking at that whole person. We're complex creatures, we're dynamic in nature. We have to look at the whole person. If we don't look at the whole person, we're kind of sending them away with a half of a treatment plan or a half of a chance at a solid outcome. At People Incorporated, we are really working with some of our most dynamic and vulnerable folks in a whole person model, looking at how do we really assess for the whole individual, try to create a treatment plan that actually addresses the whole individual, hoping that what we get on the back end is in fact something that not only produces great outcomes and a higher quality of life, but is actually more sustainable fiscally as well. We can't keep looking at this particular population and in particular and saying, well, we need to cut money out of the healthcare system, so what we need to do is kind of squeeze at this end of the pipe. It doesn't work. We have record high numbers of suicides in this country, record high numbers of opioid deaths in this country, and our largest expenditure is healthcare. Shame on us. We can do better, and hopefully we'll start today.
Great, thanks, Jill. Okay, so who do we have next? I can't see because it's hard to get around. So
That would be me.
this is yours. This is Lacey.
Yes. So Lacey Hart, my ongoing joke is someday I will write a romance novel with that name. So I was born at Mayo Clinic. I've actually coded at Mayo Clinic, and I'm still 20 plus years at Mayo Clinic. However, I spend all of my time outside of Mayo Clinic. So what I'm here today to talk about is something we've learned with a collaborative. It was a growing group of individuals very concerned about the fact that we keep looking at all the things that we do, but not the things we don't do. So if you look at any quality improvement project in a healthcare system, it's focused on technology, it's focused on process, very little focused on people, and even less on actual relationships. And so we really started kind of taking a step back. With that was born the Safety Learning System Collaborative. It's a growing group of hospitals and now outpatient clinics as well and community care. I've now been in 105 hospitals over the last 3 years in the United States, Australia, and Canada. Scary thing is they're all the same. We talk about healthcare in the US, but they're actually very similar. What we found is that we're all just humans taking care of humans. Why do we keep talking about technology and process and protocols? What happened? We're humans and we care for each other. So how do we do that better? And we landed on relationships. So instead of focusing on process and protocols, why are we not focusing on relationships? And the two I wanted to bring up today then were just what we're finding. So we do case journey reviews. We've reviewed over 500,000 patient journeys. In doing that, we look at the care teams, the communities, the family members, what's the impact, because we all have an experience around that healthcare journey. In the practice, we've confirmed 80% of what we fail at is what we don't do. It's not what we do to each other, it's what we don't do. And the really sad thing to me was uncovering that much of what we don't do is because of our biases of mental health. So patients come in, they're anxious. They get a psychiatrist referral. And then 2 days later, we're reviewing the case because they die, because we didn't recognize that they were actually septic. So this is just our own biases because we're unwilling to really think about what is it we're caring for, and that's a human being, and what are all of those things that we're missing. And then taking care of our own, how do you think that staff feels when their patient dies or is harmed or they don't have someone to turn to? You mentioned suicide rate. The top suicide rate of any profession internationally is what? Physicians. And it's equal gender, so it's affecting our care teams. We're also having the highest exodus of any profession. They're leaving, and they're not just leaving for other professions. They might be going into academia or they're going into startups, but they're leaving caring for humans. So when we start looking at that, what's happening, it's really that we're relying on superheroes instead of taking care of our own. And so again, that's 105 hospitals that are proving that out. So what are we doing about that? The next slide. I did have 2 slides. I cheated. I did 2 slides. But that's really what we're doing. So when we go in and we start looking at these hospitals, we don't take the traditional quality improvement approach. We actually look at what's the ecosystem and where are all the intersections of relationships. And then getting healthcare systems and communities and those that they work with to recognize and embrace those relationships and work on those relationships, understand common pain points, enable communication, embrace what is actually still taught in medical school but you don't see in our healthcare system, that healthcare is both a science and an art form. And solving the problems and tailoring experiences so that we can evolve and mature the journeys for all involved.
Okay, so I'm going to pass the mic to Aaron.
I've got my own.
Okay.
I don't have a slide. My name is Aaron Huey. I founded Fire Mountain Residential Treatment Center in 2009. Before that, we were a kids camp and teen rite of passage programs. I've spent my time in recovery, which is now 22 years, on that proverbial eternal 12th step. Thank you. Thank you. The 12th step of recovery, which so many people in our industry, in mental health recovery, is about helping those who still suffer, find a way to help those who still suffer. And through our kids camps and our rite of passage programs, we finally just had a mom call and say, can my kid just come live with you? And we said, okay. And a week later, we had 6 teens living in our home and 4 on a wait list. And moving forward, now we have a residential treatment center in Estes Park, Colorado, and a hit podcast that's giving back. And when I listen to all of us, what I see the common theme is we all still want to help. And we're caught up in a system that has so many varying degrees of help, so much science behind what help is supposed to look like, insurance companies who are only going to pay for certain kinds of help, and a lack of oversight to make sure that the people are actually covering these families who are suffering some of the most devastating experiences that you can possibly have. And that's a loved one dealing with mental health or addiction. And because what might work for you won't work for you, might work for you, does work for you, and absolutely does not work for me, even though we are all suffering from the exact same mental health disease or substance that we're addicted to, how do we get behind and say we need to fund this type of recovery? The simple answer is exactly what we're talking about, is connection. At the beginning of our Parents' Weekend, I will say to the parents, hey, raise your hand if your child has called Child Protective Services on you because they were angry. And I'll see a parent raise their hand, and I'll say, look around. And that person will look around, and there will be 8 other parents with their hands up. And they will automatically just, oh, you, me, you? And I will say, how many of you have had your kids steal your car? And the hands will go up, and they'll look around, and the tears start. Is because in mental health and addiction, we still suffer from terminal uniqueness. And it's being promoted and propagated by agencies that don't work on the human experience, the deep connection level, and insurance companies who will take your money but not reimburse it when you ask for what you're paying for. And a government system that still is unwilling to invest in emotional intelligence. The thing is that everybody in this room, everybody in this conference, we know what works. And we're spending our lives and our careers trying to facilitate what works. And we're looking for someone to get behind it and support it. So at the end of the day, we're dealing with isolated, alone, scared people in a system that's so overwhelmed by a society that isn't ready to pay for it. And it feels like a no-win, but this is the fight. This is why you get in, and it's why you stay in.
So I'm just going to pose some questions to the panel, or at least one to get us started, and then I really hope that the audience is going to pitch in and ask some questions that I hadn't thought of. So I'll just maybe take a moment to talk about what I'm seeing in Canada in this space. So we've been, it's also our 10-year anniversary, supporting individuals who are struggling to gain access to care in Canada, and we're all about basically a matchmaking service of getting the provider and the patient connected. And so what we found, though, is mental health, that they needed so much more than just access to a psychiatrist. And so I think what I heard a lot about is that we're trying to find cheap ways, inexpensive ways, the quick fix to fix mental health. But what I also heard was that's not the answer. Human capita relationships is the way to solve for mental health, and what works for one individual doesn't work for another. Customized care plans, right? But still that relationship of human capita. And that's exactly what we're finding. So I just want to kind of provoke that thought process a little bit more and ask each of you to kind of give some thoughts on that.
I think it's really important to distinguish between serious mental illness and non-pathological, normal life in the world as it is today. We spend so much money shaming people for having normal reactions to challenges. I'm sure some of the kids, we talked about this yesterday, who come to your program are fine. The problem is that the parents don't understand how to help them develop. And so it becomes more and more exacerbated as the patient becomes more and more pathologized and shamed. I think at the outset, we have to really look at our culture and say, we need to rethink this whole idea of mental health and start separating out different kinds of issues. What we all struggle with day to day, which 100 years ago would have all looked like mental illness, has become our normal, but we're ill prepared for it. So for almost no money, it's very easy to create community spaces, whether it's within existing community health communities or it's in other areas that the government supplies spaces. In our case, we have a free studio called DIY Human where people are invited to just come and share their thoughts, share their stories. And guess what? When we feel heard, as everyone here is saying, we're better. So if I tell you that I felt ashamed that, I misspoke about something, you're likely to think, oh yeah, I know what that feels like. And all of a sudden, I'm better. That didn't cost very much. Someone else?
Care is expensive, and quality care is very expensive. And not just because somebody has decided it should be expensive. It's because for 18 kids, I have 36 staff. Because that's the right thing to do, is have that level of care for a child who we are stewards for. And for a family, it's not just about, oh, my child's broken and I'll come back in 4 months to pick him up. There's no such thing as a broken child. There's a broken system in play, and so you have to address the entire system, and that's costly. And so once again, we come back to a place that we've got programs, and they might have 120 beds, and every staff member there really wants to help and heal and fix and serve the community that maybe once helped and healed and served them. But they're not going to get enough funding from the state. So they're going to lose staff that are going to make money elsewhere or make a living elsewhere, and programs get shut down because of lack of staff, and those kids have nowhere to go, so there's overcrowding elsewhere. And then your only option is left with either nothing or an expensive treatment program that is providing quality care and quality service. And they don't have the support for that. And unless you have the income for it, you don't have the resources for it. So I think one of the answers to this, whether the system is a socialized system or not, is that the people who are involved in providing care have to also provide the services for free. You have a way to provide the quality care, but what else are you doing? What is your purpose branding? What is your purpose marketing? For us, the podcast is a way of being able to talk to all the experts and get it into the hands of the parents just as they're getting concerned and looking for support so that they can try to keep their kids out of treatment. So how are we serving our communities? That's our responsibility as care providers, is to not just provide that pound of cure, because that's expensive emotionally, physically, mentally, spiritually, and financially, but to also, what are you doing for the community you're in? What are you doing for free? That's our responsibility.
And I would argue it doesn't have to be done for free. I'll also argue a little bit about the elephant in the room is healthcare actually is big money. It has money, it's just not always in the right places. But I will talk to just a bit about the providers. One of the things we challenge when we go into hospitals, the providers can't do that extra mile if they don't have the bandwidth. We only have so much room for ourselves to flex and provide that additional care for our patients. And so where do we find that? But it's fascinating to me how there's very little programs. In fact, there's only one program that I'm really well aware of for providers, and that's the Johns Hopkins model. The Johns Hopkins model is a pager system that if you had a difficult situation as a provider, you can page another provider. Aren't they already busy? So there's got to be other models. When we challenge and say, well, what else can you do? Say, oh, we have no money. What's your marketing budget? So we do call them out and start asking where their money's allocated so that they can free themselves up to do what they actually went into medicine to do, which is exactly what you're talking about.
Yeah, and we talked a bit about, Lacey, when you and I were talking before the panel, was this pay-for-service model and what it's creating some challenges for the providers in that there's so much paperwork. And I think actually this morning, our guest speaker that kicked us off, Amin was his name, Amish. He talked about that, right? So just following that premise, and Jill, we talked a bit about how this fee-for-service model. I'd like to know what your thoughts are on, is this the right way to go? We just haven't figured out all the kinks in the model, or are we off track and there's some other way we should be going about solving this?
So one of the things that I want to kind of sort of strip this back to the basic level. There's so much of this that's really about almost either one of two things, either fear or just inertia, right? Some of what we put in play years ago was a parity model around behavioral health care. And I can honestly tell you, coming from the state of Minnesota, where it was a very big push from one of our former state senators, we still don't have parity in the state between behavioral health and physical health. And that's a big problem because it creates this standard that this is somehow less important. Even though you may never have heart disease, I may never have diabetes, but we'll all have mental health. I'm just not sure at what level. But we're still finding ourselves kind of driven by the fear of the stigma, driving that stigma into thinking that somehow we don't have to make really responsible, far-reaching decisions about what's appropriate and not really actually seeing mental health, chemical health, whatever you want to call it, behavioral health, and physical health as pair. Yet, what we know is that depression is inextricably linked to diabetes care, to cardiac, and we see terrible outcomes where individuals physically are basically recovering from a major medical episode like cardiac or maybe being diagnosed with diabetes and not compliant with medications, struggling with depression or depressive-like symptoms, and as a result, it is inextricably linked to their inability to actually progress from whatever else their physical selves were being treated from because of their depression. So we see this, we see the data on this, yet we somehow act like and think like it's okay for us to look at behavioral health, mental health, in some way different than we would look at anything else. If you had mobility issues and part of your recovery from a physical ailment required you to get to physical therapy, we would, in the system, find a way to get you there. It's really not any different with mental health. If you have mental health-related issues and your recovery depends on you getting some other type of service and transportation is a barrier, it's still a barrier because we don't pay for it. So we have to think about this from really the bottom all the way on up. What is our philosophy and what are we putting in our way of actually letting the philosophy stand up in a bigger way? And then getting to the tactical pieces and acknowledging that tactically we can put in all kinds of things that are going to make us better in a more integrated way. But at the most basic level, we've got to start by acknowledging that this isn't somehow an issue we don't have to address.
I'd just like to add that, there is, the mind-body connection. And one of the things I struggle with, I train residents in family medicine and psychiatry, both at the University of Oklahoma College of Medicine. And the big thing I struggle with is closing that treatment loop because psychiatrists have such a completely different method of treatment than psychologists and master's level counselors. So it's closing that loop on getting a uniform standard that they can all agree upon. My take on it is medicine rarely should be the first option when treating mental health. And secondly, it's getting primary care physicians on board, even closing the loop further with what psychiatrists, psychologists, and counselors are doing as well. Because the frontline people, those are the people that are seeing these different types of psychopathology on a daily basis. And the more primary care, family medicine, internal medicine can be on board with what we are doing on the mental health side, the better it is for patients all around.
I don't think that psychiatrists have one way of working, and counselors or marriage and family therapists or social workers have another way of working. People have philosophies, whether they're trying to be Freudian or Jungian or behavioral modification or whatever that thinking is. It has nothing to do with the profession. In my opinion, we are very limited by the fact that typically psychiatrists write prescriptions. Well, that prescription, as everyone here is saying, may have very little to do with the individual. So two people who have the same symptoms may not have the same disorder. Symptoms are one thing. Mental illness is a very different thing. And until we are willing to look at individuals and consider what would be the best treatment, because you can give somebody a drug or you could give them a group therapy experience among peers that can be life-changing. When you sit with a therapist one-on-one, and I am a therapist, so I'm saying this with appreciation for the field, what's inherent in the room is that the therapist has it together and you're messed up. And that's why I like groups, because you have a bigger perspective. We have to stop pathologizing emotional differences and emotional struggles.
So I think we have time for a question from the audience. I missed my 15-minute window markers, so could we maybe open it up? Does anybody have any questions out there? Yeah, see one hand.
Thanks. I had a question for you guys about compassion fatigue and your workers, people that work in your organizations. You know, a big part of a problem I feel like we have in the mental health world is staff getting burnt out and having amazing people with brilliant ideas leave the industry too soon because they don't really know how to properly take care of themselves. So I wanted to kind of ask you guys, you know, what are some ideas that y'all might have for people who are working in this industry as employers as something we could do to help our employees stay motivated and take care of their own mental health?
We have a program that we call the 12-Minute Connection. And you can do it for your entire organization or a department. And the idea is, over a finite period of time that you decide, every person in your organization has a one-on-one that is very private and very meaningful with every other person. So imagine if before we started this session this afternoon, we were all invited to meet each other. Hi, what's your name? Go around to the tables. The whole atmosphere would shift. It's really important that we understand we need to know our colleagues just the same way that we need to know our patients and our superiors.
I like that answer. I will speak just from large organizations. So in large organizations, sometimes it's a little more difficult. But what we're finding in these large systems is something we call learned helplessness. And it's rampant. And every time I ask, what would you like to do or what would help you free up some time, everyone panics. It's like, oh, I gotta do the EHR. And oh, Joint Commission showed up. It's all these regulatory fears. And if you can remove that and say, if you could do one thing today, and so we actually, many of the hospitals just have this online feedback form. And it's if they could just remove one barrier to do one nice thing for that patient, what would it be? And it's fascinating how many times leaders get back to them and go, why didn't you do that? Go ahead, it's okay. So it's just giving them that permission to do what we do best and take care of each other.
And as an employer, I think you have a responsibility to fulfill some of the emotional intelligence training the industry we're in is unbelievably triggering. You're going to be triggered. Back to your childhood, mommy issues, daddy issues, everything. You're going to be working with children who have been going through the same thing. You're going to be triggered. And having a system in place, whether it's flex dollars that they can spend on their own therapy, cookouts, team building stuff, trainings with other experts in the field in different areas of therapeutic modality, it's going to come back down to emotional intelligence. I thoroughly believe in the mental health field that if we began teaching emotional intelligence to children, it was part of a standard curriculum all the way through college, we would all be out of business in a good 50 years. It would be done. And if that's what we're doing, is manifesting an environment of an emotional intelligence, it has to be part of the staff's curriculum as well.
So universities are now using our DIY human cards to combat loneliness and suicidality. And they're using it in orientations and freshman dorms. Again, these are very inexpensive, simple ways for people to be mirrored and to realize they're not alone.
I'd just like to add, I did a 5-year study at a large academic medical center looking at predictors of burnout and retention among physicians, residents, medical students, PAs, PA students, and all other medical staff, including RNs. And some of the evidence that I received was alarming, but one of the big things that we noticed that showed very significant results, which would be a take-home message for you, is peer-to-peer mentoring. And we saw tremendous results and up to 20% improvements in satisfaction and reductions in burnout based off that one simple method.
Okay, so do we have time for one more, or we're cut off? We have time for one more question. Anybody else have a question? Okay, great.
On the aspects of treating mental health, most people go to, like you were talking about, a specific, whether it's a psychiatrist, a mental health coach. That's how they're viewing the body. So what if their mental illness is more of a biochemical imbalance? What if it's a neurological imbalance? How do you either create a team or a network or the communication in between the specialists?
That's the closing the loop I was talking about. So that's that's a big piece we're missing in healthcare, is closing the loop. And when I'm training residents in psychiatry, I am told to stick to a specific protocol in regards to that training, in regards to educating them on how to handle their patients. And I also work with clinical psychologists as well, and so that message is actually totally different. So one of the things that I'm told to do is totally different in regards to curriculum. So one of the things I try to do is try to merge those two things together and create a uniformity with it. And then, like I said, pulling in primary care and internal medicine and getting them involved in the treatment process as well. Because like you said, if you don't have the doctors, if you don't have the people on the front lines that are involved in that treatment, it's just you're not gonna have good outcomes.
I think in the integrated model, which I'm a huge proponent of, which goes beyond just integrating within a specific health system, is really integrating farther beyond that, not only in terms of the integrated care the individual receives, but also the way that they receive it in the community. For us, a lot of our population is working with physicians in a medical setting. They're working with maybe independent psychiatrists. They're working with community support entities around everything from case management to transitions to living to whatever might be going on, particularly if they're at a little bit deeper need of the spectrum of what they're going through. And we've got to find a better way to work harder at making sure that we're all talking about the client's care in an integrated way, because it actually takes, in particular for someone who's really in crisis with their mental illness, it takes a lot of different caregivers to actually be able to help them kind of get reset back on a path. And unfortunately, that is probably the one thing I can say we do not do well right now. We're making some real progress in a lot of areas around integration. Communication is not one of them.
I think another piece is that once we figure out how we get all the doctors and the nurses and the talent on the staff connecting with each other around an individual, we've still only solved 50% of the problem, because now we're still focused on a patient, just like the family was focused on that child or that one family member. You have to integrate the entire family in the healing process as well. Dr. Patch Adams was one of my early mentors, and he said, your grandmother does not have Alzheimer's, your family has it. And we have to treat the whole family, not just your grandmother. It's a beautiful concept, and it's, for a lot of facilities, very unrealistic. But even if we have a talented medical and mental health team that really has the full wraparound, if the family is not treated with a full wraparound, integrative community support process, you're still focused on one person's problems, and that's never the cause, that's the result.
Okay, so I think that's it, but I hope and I encourage you all to meet up with our panel and ask any questions you didn't get a chance to ask, okay?